you already knew because you registered for this specific topic. What is available for maintenance therapy is our session today. Now, this is the third of 3 sessions. We started with Know Your Myeloma Therapy, what's available for induction. Then we did consolidation. And now we're here at maintenance therapy. Now, I know this is a hot topic for a lot of you. You're very curious about maintenance therapy. Some of you are wanting to get off of your maintenance therapy. Some of you don't even know what maintenance therapy is. So we're all here together. We're here to learn. I'm excited to learn with you. And we're just going to get into it. So Dr. Raleigh Fatoki is recently graduated from his internal residency at Kaiser Permanente in the San Francisco Bay Area. He then made the big move to Miami, Florida for a fellowship at the Hematology Oncology Center in Sylvester Comprehensive Cancer Center with a special interest in myeloma. And I'll keep it short and sweet at that and turn the time over to you for your presentation. Thank you for being here, Dr. Fatoki.
All right, good evening, everyone. Let me get my screen shared. All right. Oops, excuse me. There we go. All right, can you see it?
Yep, looks great.
All right, hi, everyone. My name is Fatoki. As Audrey mentioned, I'm a fellow at the University of Miami Sylvester Comprehensive Cancer Center. Looking forward to joining you all for this discussion today. I like to give the disclaimer that, I'm still a fellow, so I am in training. And so though I have this deep interest in myeloma and I'm developing my expertise, I don't call myself a specialist yet by any means. I'm really looking forward to, sharing some of this information with you and hearing a little bit more about your experiences and some of your thoughts and wishes for the future of maintenance therapy. So let's kick this thing off. I just want to start by saying I don't have any disclosures. And so the agenda for today, I'm going to first start off with what I call the Myeloma 101. And I think it's important that we hit this, every time just so that we remember, what it takes to actually meet the diagnosis of myeloma, because that can sometimes be confusing. And then from there, we can talk about the treatment options for myeloma. But, I do want to start off with just an overview. Then after that, we'll get into some background about maintenance therapy in general. We'll talk about some of the different options for maintenance therapy. We'll talk about, how we select patients for which types of maintenance therapy. We'll get into a little bit about why we do maintenance therapy in the first place. And then at the end, we'll talk about the future of maintenance. And that's where I'm really interested in some of your thoughts and questions about, what are you hoping for from the patient perspective? Because I have some things in mind, but really interested in having that discussion today. All right, so let's jump into Myeloma 101. And you all will hear this throughout the presentation, but I'm a huge myeloma fan. I joke and I call it the investigator's malignancy because it's, it takes some investigative work and it takes some thinking to really get to the diagnosis. But first, we'll start off with the definition of multiple myeloma. And so, my definition of myeloma is, in layman's terms, or as simple as I can put it, this is an incurable blood cancer that involves plasma cells. So I'll say that one more time. This is an incurable blood cancer that involves plasma cells. That's kind of my simple definition. And I think it's important next to highlight that, plasma cells are a type of cell that's produced in the bone marrow, and its primary function is to produce immunoglobulin, also known as Ig. There are various types, but that's pretty much plasma cells' main job. But what happens in myeloma is that you have a cancer of these plasma cells. So they start to become clones. So you'll have many, many plasma cells that are fairly inefficient. They don't really work in the ways that your normal plasma cells would, but you have this clonal formation. And from there, these plasma cell clones, or the cancer itself, they go on to release immunoglobulin, and that immunoglobulin can deposit into tissues and cause organ damage. And so, generally that's the way that I describe myeloma to my patients. And I feel like it's a nice framework to help understand it. It does get a little more nuanced than that, but the main idea is there's a cancer of the blood. It involves these plasma cells that secrete immunoglobulin. And when the Ig is secreted, especially in excess, it can deposit in tissues and start to cause damage. And so just thinking about how common multiple myeloma is, it actually is the second most common blood cancer in the United States, accounting for around 15 to 20% of all blood cancers. So This is something that we see pretty regularly. And for some reason, there are certain types of patients who seem to be at higher risk for myeloma. And so one is, if you're a male, you're about 30 to 40% more likely to have a diagnosis than being a female gender. Also, if you have a background coming from Africa, or if you have genetic ancestry coming from Africa, you're 2 to 3 times more likely to be diagnosed with multiple myeloma. And there's work going into figure out why that's the case. And that's something I'm really interested in. And another factor is just older age. Myeloma is a disease of older people, with the average age being from the mid 60s to the mid 70s when people are diagnosed. So this is not something that we necessarily see in young people. And as you get older, your risk for developing multiple myeloma gets higher and higher. So again, this is an incurable blood cancer. It's the second most common blood cancer in the US. And if you're Black or a man or older, you have a higher risk of being diagnosed. And so, what are some of the signs and symptoms to think about? And again, like, I know this is a basic overview. This is our myeloma 101, but I do like to hit this every single time. And the big takeaway that I ask whenever I'm giving this kind of myeloma 101 type of talk, whether it's to patients or medical students or whoever it may be, is it's all about CRAB. It ultimately comes down to CRAB. So when I think about some of the symptoms that can be manifestations of multiple myeloma, it's generally related to that organ damage. It depends on where the immunoglobulin is being taken up and where it's which organs it's infiltrating or which tissue it's infiltrating. But it manifests with these CRAB features or this CRAB criteria. And so, if there's 3 things to remember today, I think one of them is CRAB. And so the C for CRAB stands for hypercalcemia, the R for renal failure, the A for anemia, and the B for bone lesions. And so this is something that's taught to medical students and up and coming physicians so that we can be tipped off to the diagnosis of myeloma. But I think it's important that as patients and caregivers and as regular people, we understand that when these constellation of symptoms start to show, we should really be thinking about multiple myeloma. And ultimately, to diagnose myeloma, you need a combination of 2 things. One is a bone marrow biopsy showing greater than or equal to 10% of plasma cells in your bone marrow. So your bone marrow does need to be, showing signs that it's being taken over by these clonal plasma cells. But the other piece of it is that, these cells need to actually be causing damage. And so you need one of the CRAB features or one of the CRAB criteria in order to meet the formal diagnosis of myeloma. So for example, if you have 10 or 15% plasma cells in your bone marrow, but none of the CRAB features, you would not technically meet the criteria for multiple myeloma. And so again, it comes down to CRAB. If you have CRAB, if you have at least one CRAB feature and at least 10% bone marrow, at least 10% plasma cells in your bone marrow, then you have the diagnosis of multiple myeloma. Okay. And so I know there's everyone's at different phases in their disease course. I know there's probably lots of different questions, but today we're really going to focus on maintenance treatment. And so if you could think about the kind of schematic or the way that things normally flow, you get a diagnosis, you generally receive some form of induction treatment based on the risk of your disease and your clinician's preferred practice. You may or may not receive an autologous stem cell transplant. And after this induction treatment, plus or minus the transplant, you're likely to receive maintenance treatment, okay? And so for today, we're focusing on the maintenance portion. And so there may be questions about induction treatment or transplant, and I'll save those to the end, but the focus for today is maintenance treatment. So what does maintenance even mean? Maintenance treatment is defined as treatment given to help keep cancer from coming back after it has disappeared following the initial therapy. So again, thinking about it, we're giving this strong upfront induction treatment or this initial treatment to try to get the cancer under control. But in the back of our minds, we know multiple myeloma is a disease that currently has no cure. And so the idea is, well, since I can't cure this, even if I can get the myeloma down to a very low level, I still need to give some form of treatment in order to keep this disease under control. And so almost all patients with multiple myeloma end up with maintenance treatment, but we'll talk later on this evening about kind of what the future holds, because I know not everyone is interested in being on the medication forever. And the way we determine which type of treatment or which type of maintenance treatment you can get is primarily based on two factors. One is your risk of multiple myeloma, and I'll mention the high risk criteria in just a moment off to the right of your screen. And the other piece is if you're eligible for a transplant or not. So it's if you're higher standard risk, that's one of the first branch points that helps determine which type of treatment you get and if you're eligible for transplant. And knowing if you're high risk or standard risk is something that's very important. And I think, that's a conversation everyone should have with their hematologist or with their myeloma specialist. Because if you have one of these high risk features, I think it's important to know. So those would be a translocation of chromosomes 14 and 16, translocation of chromosomes 14 and 20, a deletion of 17p, translocation 414, or a 1q gain. And so these are all things that your myeloma specialist will know about from the time that you have the diagnosis, even before you start treatment. And so I think it is important for patients and family members to know, do I have standard risk myeloma, or am I dealing with a high risk myeloma where a different form of treatment may be involved? And so, thinking about just in general, the maintenance options, one way that I like to simplify this is that, if you have high risk disease, you're more than likely going to end up with a 2-drug regimen for your maintenance therapy. And if you have standard risk, you're likely to end up with lenalidomide for your maintenance therapy. Okay, so this is going to be a big takeaway for today, and we'll continue to harp on this. Again, maintenance therapy for most people, the standard risk people, involves lenalidomide. Maintenance for high risk patients involves 2 drugs, one of which is lenalidomide. And so as you can see underneath the high risk bullet point, based on what you get for induction, that determines the type of treatment that you get. So for example, if you got daratumumab and bortezomib and lenalidomide and dexamethasone as your induction treatment, we would generally give bortezomib and lenalidomide as the maintenance. So, we give lenalidomide because that's kind of the backbone of our maintenance. And then we add on bortezomib to that because the high-risk patients seem to have worse outcomes. But for patients who get a 3-drug regimen of daratumumab, bortezomib, and dexamethasone, we still use the lenalidomide as the backbone of our maintenance therapy, but we can add on daratumumab. And again, the difference between, this second example compared to the first one is in the first example, the patient received both bortezomib and lenalidomide as induction and then got them both as maintenance. In the second example, there's a typo there. In the second example, it was daratumumab and lenalidomide with dexamethasone. And so you end up giving similar or the same medications for the maintenance. And so again, the takeaway here is if you have high risk, you're generally going to get a 2-drug maintenance regimen that includes lenalidomide. And if you have standard risk, you're generally going to receive standard lenalidomide maintenance. Okay. And again, this is for the standard risk patients, this is regardless of which induction regimen is used. Lenalidomide seems to make a difference in outcomes. And so, just thinking about how we select patients and how we make these decisions, as I mentioned, it's based on risk and it's based on transplant eligibility. So we just talked about high risk patients and how, the general approach is to give a combination regimen for these transplant patients. And so, I'm sorry, for these high risk patients. And so for patients who are high risk and eligible for transplant, the general approach is induction treatment, or as we showed on the slide a few slides ago, diagnosis, induction treatment, followed by autologous stem cell transplant, followed by this 2-drug maintenance. And we generally continue that until disease progression. So that means you're on these 2 drugs until there's a problem. And the problem being that the cancer is growing or the toxicity becomes too much. But there really is no opportunity to get off treatment for these high-risk patients. And the same goes for high-risk patients who are not eligible for transplant. The general recommendation is still 2-drug maintenance until disease progression. And so, in both of these 2 examples, the high-risk patients, they're going to receive lenalidomide as maintenance, and you can either add on bortezomib or daratumumab based on whatever the induction regimen is, as we spoke about on the last slide. So again, high risk, you're getting 2 drugs for maintenance for a prolonged period of time. However, for standard risk patients, especially those who are transplant eligible, who receive transplant, our practice is actually to give lenalidomide maintenance only for 2 years. And I know there would be some questions about this, and this is an area that I'm really excited about because we're starting to explore this idea of maybe we can stop treating someone. And I think that's exciting to me as an oncologist because whenever I think about this idea of me not treating someone, but the cancer is not growing, I have to ask myself, well, have we cured this patient? And so when I think about the future of a cure in myeloma, this idea of being able to stop maintenance therapy gets pretty exciting. But again, standard risk patients who are eligible for transplant and receive transplant would generally receive lenalidomide maintenance only for 2 years. And as long as the disease is under control, you could consider stopping. And then standard risk patients who are not eligible for transplant, they continue on indefinitely, similar to the high risk patients. So as opposed to the high risk patients receiving 2 drugs indefinitely, standard risk patients who do not receive transplant generally receive lenalidomide indefinitely. Okay. And so I'm not actually getting into the specific trials and the specific trial data, but I did want to kind of take some time to kind of discuss the broader picture about why it is that we do maintenance therapy. So as I keep harping on, myeloma is an incurable disease. So that means that even if you can get the disease, quote unquote, under control or in a remission after the induction therapy, almost everyone will relapse and need additional therapy down the line. And I think part of the concern or part of the rationale for wanting to use maintenance therapy is that, these relapses aren't necessarily benign. These could potentially be life-threatening relapses. We're thinking about the crab criteria or the crab features. Imagine the progression of disease manifesting as renal failure that could potentially be life-threatening, or manifesting as bone lesions and fractures that could potentially be life-threatening. And so, given the fact that there's serious morbidity or bad outcomes that are associated with disease progression, the idea is, well, you know what? Yes, there may be some toxicity in giving additional treatment for a prolonged period of time, but maybe I can hold off the really, really bad thing from happening, down the line. Maybe I can push it off for another year or another 3 years. But ultimately, almost everyone will need another form of treatment. The reason we use lenalidomide is that multiple clinical trials have actually showed a survival benefit to adding lenalidomide as a maintenance therapy after transplant. So not only does it increase the amount of time until the next relapse or the next disease progression, it seems to also prolong life. And because of that, being seen in the transplant setting, we kind of extrapolated that data for the patients who don't receive transplant. Again, the thought being, well, you know what? This made such a difference in our patients who are receiving transplant. Let's just do this for everyone because we want to help as many people as we can. But unfortunately, high-risk patients, even with maintenance and even with our novel therapies, are having worse outcomes and just not doing as well as standard risk patients. And so because of that, that's the reason why these combination-based therapies have begun to be explored, and there is some promising data. And so thinking about the future of maintenance therapy, and this is really where I wanted to spend a lot of time in the Q&A. We don't necessarily have answers to these questions just yet, but I think it's important for us to be thinking about them, not only from, my perspective, like the physician's perspective, but also from the patient and caregiver perspective, because, my job is to help you live longer and help you have a better quality of life with your disease. And if my treatments aren't necessarily doing that, then I should think about doing something else. And so as I think about the future of maintenance and some of the ongoing work and some of the questions that, I have and other specialists have is, how long should we really be giving maintenance? Is it 1 year? Is it a year and a half? Is it 2 years? Is it 5 years? What's that optimal duration of treatment time in order to get the most prolonged remission that we can, or even to get to a potential cure? And that's an answer that we do not have yet. Another question is, should measurable residual disease factor into this decision-making? We have new tests that are able to detect cancer cells in 1 in a million. Should we be using that to help guide patients, on whether or not they should receive maintenance therapy? There was a trial published last year, a master trial, which was a phase 2 MRD study looking at surveillance. there is promising data, and I know patients are really interested in it, and I know I'm really interested in it. So we'll see how these next few years go in terms of maintenance therapy, but MRD is being explored as a way to assess whether there is microscopic or 1 in a million cancer cells left over. Other thoughts that are being entertained are this idea about combination maintenance therapy. It seems to be making a difference for our high-risk patients, and there doesn't seem to be additional toxicity associated with it. And so a question that's being asked is, should we be considering combination maintenance therapy for everyone? And another piece that I think doesn't get talked about enough, but something I'm very interested in is, what about the cost? Some of these drugs, I'm thinking about lenalidomide in particular, can sometimes cost tens of thousands of dollars per month. And now here I am, the myeloma doctor talking about keeping you on this expensive medication for years. In theory, the goal is that you would have a remission and be on this maintenance therapy and not have disease progression for years. Should I be thinking about the cost as we factor in maintenance therapy? And then the last piece, and again, something that's not really talked about enough, is the risk of secondary malignancies. Lenalidomide is known to put us at a higher risk. Those who take lenalidomide are at a higher risk for developing a secondary cancer unrelated to the myeloma, but directly a result from the lenalidomide treatment. How much of this do we accept, or do we say, what, lenalidomide is too risky and we're better off dealing with the disease progression as it comes, and maybe we should hold off on maintenance therapy? So these are some of the thoughts these are some of the questions that are being asked, and some of the thoughts that are being entertained. And I'm looking forward for the future of where we take things. And so with that, I'll finish up so we can have a lot of time for questions, and just really more of a discussion. But some of my takeaways are, high-risk patients generally receive a two-drug regimen for maintenance therapy, which generally includes lenalidomide. Standard patients generally receive single agent or lenalidomide on its own. We really don't know how long to give maintenance, but there is some promising data supporting MRD-based surveillance. So using measurable residual disease to detect 1 in a million cancer cells. And if you can't detect it, maybe that's an opportunity to take someone off of treatment so that they can enjoy their life. And so with that, I'll finish up the kind of lecture portion of this so that we can have more time for questions and discussion. And I just want to say thank you. So I'm going to have my takeaways here, and I have my email. I'm located in South Florida. As I mentioned, I'm at the University of Miami Sylvester Cancer Center. I'm very interested in myeloma, especially in disparities in people of African descent. So if there are any questions or any ideas or any collaborative thoughts, feel free to reach out.
Thank you so much. That was so great. I love the way that you explain things so clearly, and the questions that you posed at the end are just so relevant. Excellent job. Excellent job. I open it up to my audience. If you would like to, I'm seeing reactions here. People liked your presentation as well. I love when you guys use reactions because it helps us know that you enjoyed the content. The Q&A is open, so there are some questions already. I would love for you guys to put more questions in there so that we're able to have a great discussion. I'll start with one that was asked to me previously before we started today. And if you don't mind, I'm gonna end your sharing so that they can see you more clearly. Maintenance therapy, sometimes patients are worried, A, about the financial aspect, but B, of the toxicity, because they're not realizing that maintenance therapy is at a much lower dose than their induction therapies that are given to them. Can you give examples of dosages that would be given in induction versus maintenance therapy so that patients can start to understand the minimality, that's not a word, the low amount that's given in a maintenance setting?
And I'm sorry, I don't have the exact dosages on the top of my head, but generally the way you could think about it is, induction therapy is that upfront therapy where you're trying to hit the cancer as hard as you can. So, of course you don't want to be toxic to the patient, but the idea is let's give as much therapy as we can, or as the patient can tolerate, in order to defeat this cancer. The maintenance therapy, I would think about it as, a much lighter regimen. So it's similar to what you received up front, but maybe at 30% of the dose, 20 or 30% of the dose, with the idea being You want someone to be able to take this for a prolonged period of time without having a huge impact on their quality of life, with this still with the same goal of keeping the disease under control. So if I were to put it simply, I would say, you could think about maintenance therapy being at like 30% of the level as you might receive an induction therapy. And that's not just for multiple myeloma, that's for, cancers in general. Maintenance therapy is generally much, much easier to tolerate than the induction therapy.
Great, thank you. That was going to be my follow-up question. Do you see the quality of life of these patients improve on maintenance therapy versus when they're in the trenches of these induction therapies?
Oh, definitely. And, I have some patients who generally feel terrible during induction therapy, but you can feel a lot better. You feel like you have your life back when you're on maintenance therapy. But this doesn't necessarily apply to everyone. And I think that's why it's important for us to keep asking these questions about, how long do we give maintenance therapy? How many drugs should we give? Because some people even feel terrible on maintenance therapy where they can't even tolerate it. We're having to reduce doses and eventually stop the medication, not because their disease is well controlled, but maybe something that's factoring us into taking a surveillance break is just it's destroying your quality of life. And so I think it's a balance, but it's important to recognize that generally you will feel better, but it's patient dependent and everyone's different.
Yeah. You and I talked earlier, this isn't just a patient-dependent disease, this is also a physician-dependent disease. At Sylvester, where you are a fellow, what is their general practice, or is it provider based on how long they keep their patients, even standard risk, on maintenance therapy?
I have seen a little bit of provider dependence, but I'll say across the board, I think we generally follow the same protocols and most patients are on maintenance therapy indefinitely. But there are situations where a provider may feel more comfortable putting a patient on surveillance or taking them off of treatment because that's what the patient is asking for. And their clinical course kind of suggests that they have more of an indolent or a less aggressive type of disease. But that is not something that I've seen regularly outside of clinical trials. But that is something I'm very interested in. You'll sometimes hear me joke about an East and West Coast mentality for myeloma treatment, where some people believe that less is more, and so I do believe that maybe a better way to describe it is it's not so much provider dependent, but it's cancer center dependent. Where there are some cancer centers where you may be more likely to be encouraged to be watched under surveillance as opposed to being on maintenance treatment indefinitely.
Yeah, which is something that we also talked about, this idea that second opinions are so important in making sure that whether, your provider is saying, oh, maybe let's take you off of maintenance therapy and that scares you, maybe go seek a second opinion. Or if it's the other way around, your quality of life is just deteriorating, you're unhappy on maintenance therapy, you're looking for a way out and your provider's not so sure, go and seek a second opinion. And then the key to these second opinions is understanding the data behind their opinions. So not just taking it at face value, but saying to your provider, can you explain to me or provide me with resources of why you're making that decision in both the second, like first and second and third or fourth, or however many opinions you want. And then once you are an informed patient, you understand, okay, here are the options for me, here's the reasoning behind them, then you can more confidently make a decision of, okay, you know what, I think I am actually going to stay on maintenance therapy and maybe get some prophylactic drugs to help with these side effects. Or, I actually feel more comfortable with my doctor's suggestion to come off of maintenance therapy. So
No,
just
I
some.
totally agree with that. I think many of these decisions that we make within multiple myeloma are very nuanced decisions. Me as the physician, I'm making very nuanced decisions based on you as the person, your disease, and just the overall trajectory of the disease. But I don't always explain the nuance of those decisions. Sometimes and because of time or whatever it may be, maybe we're focusing on other things during the visit. All you hear is the recommendation. And so I agree with you wholeheartedly that getting that second opinion or being able to hear the rationale for why the decision was made may influence you to think like, oh, well, there isn't slam dunk, or there isn't definitive evidence supporting this decision. Maybe it's more anecdotal or historical evidence that we're using. And in those situations, you can make a decision. You and your doctor can make a decision that's best for you.
Definitely. Okay, so a question here. Let's get into the nitty gritty of the master trial just to explain it to people who are unfamiliar with it. This person is specifically asking if it's a 2-year, 5-year, 10-year, or longer period of those MRD negative tests. So if you could just briefly explain on the master trial, what is the requirement to come off of maintenance therapy? And then if you generally follow that or see that followed in your practice as well.
Yeah. So, the first thing I'll say is I don't have the master trial memorized exactly, but if I remember correctly, I believe it was 2 negative MRD assessments in a row. So you needed to be MRD negative, and then whether it was 4 or 8 months late, maybe it was at some time period after that, they checked MRD again to see, did you continue to remain undetectable or, have no evidence of residual cancer. And those patients were able to be off. And I think they've been watching them for many years afterwards. I have not seen this across the board. I have not seen this across the board. And I believe Master was a phase 2 trial. So there was no like competition arm. There was nothing to compare it to. So I'm excited. I am excited for this type of work, but I do want to see it, head to head in a phase 3 clinical trial, just so we can say definitively. But the general idea is that you have someone on maintenance therapy, you're checking to make sure that there's no evidence of disease, keep them on therapy for a little bit longer, and check a second time just to be sure. And if you find that there's no disease that second time, then you can stop and see what happens.
Yeah, yeah. I think the audience, some people might be more informed than me, but I agree with you. And it's the important part is having it consecutively, because you just get one MRD test that doesn't really tell you, just like in myeloma, one bad lab result does not mean a relapse, for example. And so it's more about the trends and what's happening. So are you trending this way? Are you trending that way with your MRD negativity? Are you remaining constant? So more than say like a set number of years, although again, physician dependent, specialty center dependent, because there are centers who say, oh, 5 years MRD negative, I'll take you off of it. Where other people are like, okay, now with these 2 consecutive MRD and negative results, might even be 3, then we're able to take you off of it. It's just, you got to be so careful, because you don't want to come off of it for a month and then have this aggressive clone of myeloma within your body, and then it really quickly comes back. Anyway, it's a great question. Like you said, there's just so much more research to be done in this area, that while the master trial is a great start, I just would like, personally, if it was like me or my mom or my child, I would like to see more data supporting um, great overall survival outcomes. Anyway, I'm rambling now, but I think you guys know what I mean. Okay. So one of the questions here is, you mentioned secondary cancers related to Revlimid. Can you name those cancers, just so that patients are aware?
Yeah, so we've seen some leukemias as well as some kidney cancers, even bladder cancer associated with lenalidomide, but there's a variety of malignancies that could potentially come from lenalidomide. I think in my mind, I think it's like less than 5% of patients will actually, get a second cancer. But the question is that too high of a cost for us to be taking? Is that too risky for us to be dealing with? So far, the answer has been no, it's not too risky, but I think that's something we need to continue asking ourselves, especially as we look into this phenomenon more and more.
Yeah. Okay, great question here. Besides Revlimid, what are other viable maintenance drugs?
Yeah, so I think I saw a question about ixazomib, and so thalidomide initially was used as a maintenance drug. Lenalidomide is generally what's used here in the U.S. Daratumumab can be added to lenalidomide. Bortezomib can be added to lenalidomide. We've looked into carfilzomib. I don't think the data is as strong. And as far as I understand, ixazomib and daratumumab, these anti-CD38 medications, can be used with lenalidomide without an issue.
Yeah, it's still in clinical trial, in terms of, I believe, maybe it came out recently. Do you know? But I know that there's a lot of clinical trials right now looking at daratumumab in combination for maintenance therapy. Tom is asking if M protein is still detected in your blood tests, is MRD testing with bone marrow biopsy of any use?
So, there are some times where you can have no M spike, no residual M spike, but there's still, that measurable or that minimal residual disease. And so we can't necessarily use the M spike as our definitive test to say, hey, there's no more myeloma left.
Yeah, I think the question was, is is if you have M spike still in your labs, is it of any use to get an MRD test?
In my opinion, no.
Yeah. Yeah, there are some very, very, very rare cases where a very good partial response is just like has these floating myeloma cells that aren't really active. And so they're MRD negative in the bone marrow, but that's extremely rare. I would agree with you. Okay. Really good questions here. I'm trying to sort them out. Okay, so Sharon has a great question. My doctor says I'm in remission, but I get a monthly infusion of daratumumab, no Revlimid since January. I also have some prophylactic medicines. She's wondering, and this is such a good question because this comes down to terminologies, right? That
Exactly.
people are using differently across the board and confusing the myeloma community. So can you please expound on that a little bit of why somebody could be considered in remission but still receiving this medication?
And that's an excellent question, and it goes back to what I highlighted as the definition of maintenance therapy. And so, maintenance therapy is treatment that we give after we've given that initial upfront therapy when there's really no disease, no evidence of disease. And so, thinking about this idea of being in remission, everyone who's receiving maintenance therapy is technically in remission. It's just that you have not been cured yet. So, disease is under control, but you have not been cured. And since there's no cure, we add on the maintenance therapy. So going back to Sharon's question specifically, it sounds to me like daratumumab is the maintenance therapy that she's receiving. But that's something that she should ask her doctor as well.
Yeah, yeah. There are some questions here that are like super specific. I'm not going to pass them along to Dr. Fatoki, but I can reach out to you personally and just help you form questions to bring to your providers. Because sometimes providers just don't explain it the way that we want it to, especially oncologists who are just so short on time and don't have the time and energy to keep up with all of this new myeloma research. So just so you know, I will be looking through this Q&A after this session and contacting some of you.
Yeah, I
If you
think
do
I see
have
a
any
lot of
questions.
questions here about MRD, and MRD is something that's very exciting. Like I see a question here: what's considered MRD negative, 10 to the negative 6 or 10 to the negative 5th? And I
Yeah,
think it depends on either your institution. For me, I want 10 to the negative 6. I want 1 in a million cancer cells, or 0 in a million. But MRD testing and maintenance testing is something that is getting a lot of us excited. And
yeah.
again, the
Charlene's
rationale,
asking, oh, go ahead.
we're all excited about it because you could potentially take someone off of treatment. Like no one wants to take a medication for the rest of their life if they don't have to. And I don't want to give someone a medication for the rest of their life if they don't have to take it.
Yeah, but we also don't want to take you off too early, which is why all this research is needed. Charlene's asking, what do you believe is the most reliable test to determine MRD? Now, for those who are super, super new, MRD, minimal residual disease. So basically, I guess that we haven't clarified this super, I mean, you talked about it, but I just want to reiterate. It's when you've reached in layman's terms, it's when you've reached a complete response. So your normal myeloma labs are showing no myeloma, but we want to do an even deeper, more sensitive test to make sure that there's not any more myeloma hiding out in there. Now, this is not a perfect test. There's multiple versions of the test. And as Dr. Fatoki just mentioned, there's different sensibilities of the test. So, with all of that being said, which do you think is the most reliable currently what we have?
And I actually don't have enough experience with MRD to be able to give an opinion on, which one's better than another. Some physicians don't even think that the test is indicated, or that they think that we should not even send the test because we don't really know what to do with it. I'm more on the interested side. So, I would love to see the results, but I don't know if it would necessarily change my decision making at this moment today.
Yeah, and most providers tend to want to do well, okay, that's a lie because there's so many providers out there. The most sensitive test is clonoSEQ next generation sequencing test. That's the 1 in a million cells that can be detected. However, most institutions don't use NGS because you need the original bone marrow biopsy sample to be able to complete that test. And a lot of patients either have a bad sample or can't find the original sample, and it just gets expensive and for the facility and confusing. So that's just why so much more work needs to be done. I don't want to scare anybody. 10 to -5 or 10 to -6, we're headed in the right direction, right?
Exactly. It's better than not knowing.
Yeah, exactly. Okay, Valerie asks a great question. Is dexamethasone needed in the maintenance setting?
Dexamethasone is not absolutely needed in the maintenance setting.
Which
Uh,
is interesting because so many people still receive it, but
it can help, but it's not something that's absolutely needed. I think, in my opinion, the most important is the lenalidomide backbone if possible.
yeah.
That isn't an option for everyone.
Yeah, this is actually an example of the question that I asked you earlier. This patient was kind enough to share. They started lenalidomide at 25 milligrams for induction and then reduced it to 10. And then for the maintenance, it's 5 milligrams. So like you said, it's a significant reduction. So thank you, Keith, for being willing to share that. And he's a patient as well. Dylan, Lynette, have another great question. Can you go from one maintenance drug to another if numbers creep up versus going to a whole blown 3-drug regimen again?
This is the gray area where I say, it may be different based on which cancer center you're on, because I think, let's say, for example, you're somebody who's not in the best shape to be receiving another round of induction chemotherapy with a combination of strong agents, and your numbers are only creeping up a tiny bit. So your myeloma specialist might consider just switching to a different maintenance regimen. But I think in general, with numbers creeping up and concern for the disease coming back, we move on to the next line of treatment and we don't even think about maintenance therapy.
Yeah.
That would be so if you were my patient and in good enough shape to receive treatment with the numbers creeping up and concern for disease progression, I would think about moving to the next line of therapy as opposed to changing the maintenance.
Yeah. Yeah. Another question here saying that they did test twice and have very, very low myeloma cells per million. Do I still need maintenance? This is where
You
your
don't really.
doctor comes to, yep. This is where your doctor comes to play, because the answer right now with all the data we have is yes, like yes, but this is where you go to your doctor. This is where you go get second opinions. This is where you figure it out, because it's your life that we're talking about. It's your quality of life. It's your what are your goals and desires, like, do you want to go travel for a while and you don't want the pressure of medication? And I think myeloma specialists are really special, and myeloma fellows, because they care about patients so much. They care about their goals. They care about their quality of life. They care about curing this disease. You mentioned, Dr. Fatoki, this is an incurable disease. I'm going to say it's a not yet curable disease,
That's exactly right.
because everything is headed in the right direction. And I just want patients to have that hope to hang on to of, this is disappointing that we can't get on this maintenance therapy and say, oh, everybody off of it in 2 years, no big deal.
Mhm.
But the progress that's being made towards a cure, go get your second opinions and ask these questions and be involved in your care, because this is so, so important. It's your life and your life matters.
And that's why I was so excited about this topic, is that, it's not like I have the answers to all of your questions, but man, we're working on it. And these are things I'm thinking about all the time. Like, even thinking back to this MRD question, I feel like my colloquial or my layman's terms answer would be, I'm pretty sure that you need maintenance therapy. Okay. But if you really, really, really don't want to, it's something we could consider stopping, and we just
Right.
both accept the risk together. But that would kind of be my answer, and that's kind of where we are right now. Is that, like, you probably need maintenance, you probably need it forever, but let's talk about it.
Yeah. Yeah. So can you become immune or refractory to your maintenance therapy, whether it's Revlimid or daratumumab?
I wouldn't think about it as immune, but you could think about it as refractory. It's like, these cancer cells are smart. They can sometimes start to outsmart our medication. That's why we have to move on to second, third, fourth, sometimes fifth lines of treatment. These treatments will only work for so long. So I don't think of it as becoming immune to daratumumab, but I think the cancer itself can sometimes, outsmart daratumumab, and then we need to move on to something else.
Yeah. Can you briefly explain what extramedullary disease is? And does it make a difference on how maintenance on my gosh, what am I trying to say? On how you dose or what treatments you give in maintenance?
So I think it depends. Extramedullary means outside of bone. So, you'll sometimes hear the phrase extramedullary plasmacytoma, which just means a collection of plasma cells somewhere in the body. And those are treated very differently than multiple myeloma. They're similar, but treated very differently. And these plasmacytomas have not infiltrated the bone marrow necessarily. And since they haven't infiltrated the bone marrow, they may not be producing as much immunoglobulin and they may not be causing as much systemic disease as multiple myeloma would. So oftentimes extramedullary plasmacytomas, in the absence of the diagnosis of multiple myeloma, we just use radiation. And so again, it depends on what you're dealing with, what percentage of plasma cells that your bone marrow shows, if you have any of these CRAB features, because if you were to have plasmacytoma plus meet the criteria for multiple myeloma, then, we're very aggressive with the treatment. Whereas, if you might have something extramedullary but don't meet the criteria for myeloma, we can sometimes use radiation and be less aggressive.
Yeah, and sometimes they still do use radiation for myeloma patients who develop or have these plasmacytomas as well. It just depends. As per everything in myeloma, it just depends.
I think that's why it's so exciting from the clinician's perspective. And I think from the patient perspective too, like, myeloma is a very exciting field because we have so many good treatments. The treatments are only getting better. We're asking ourselves if we're eventually getting to a cure. And I think there's an art to the practice.
Definitely. Okay. Okay, Steve's asking a good question in terms of MRD testing. So if M spike is not there, but kappa and lambda, because there's different ways to track myeloma, right? And so if kappa and lambda, for example, the ratio is still significantly off, is it worth an MRD test, even if there isn't an M spike?
Yeah, me personally, I would not, but some providers want to just see, like maybe there's no evidence of any residual disease and, the abnormal light chains are from some other reason, like having kidney dysfunction. So again, it is provider dependent, but at least at this point, I do not frequently use MRD to make my management decisions. More so as just another marker to keep an eye on where the cancer is or how things are doing.
Yeah. Question in your training, have you heard that multiple myeloma patients do better on a statin?
I have not heard that definitively, but I've heard like rumors or, suggestions that not only the type of food that we eat, but cardiovascular health and obesity may be contributing to multiple myeloma in general. I think there is some data suggesting that higher rates of obesity might make you more likely to have multiple myeloma. So maybe you could extrapolate from that and say, well, you know what, if I'm on a statin and I'm keeping my coronary disease under control and trying to keep my weight under control, maybe I'd be doing better with multiple myeloma. I think my formal answer or my official answer is we don't know. But I think statins and cardiovascular health and, just trying to be as healthy as you can is good for anyone, whether you have myeloma or not.
Right. And it has been shown good healthy diet and active lifestyle has been shown to reduce comorbidities, which allows you to have more access to treatments, which qualify for more treatments, which allows you to get better care. So it's like the circle of my own life. Is Pomalyst ever used as a maintenance therapy drug?
I have not generally seen pomalidomide used as a maintenance therapy. What I generally see is lenalidomide, bortezomib, and daratumumab being the main three.
Yeah. Was in terms of Velcade in maintenance or bortezomib, is it given less often? Like the risk of neuropathy with it, what kind of patients qualify for the bortezomib maintenance therapy?
High-risk patients who receive bortezomib as part of their induction therapy would generally receive bortezomib maintenance. But if you're someone who already has a history of neuropathy or you have neuropathy that's forming, we would not give you bortezomib, especially as a maintenance option, because there is still the risk of the toxicity.
Yeah, and the dose and the frequent. Okay, let's talk about frequency because we've talked about dose reductions.
Mm.
Is the frequency also less often as an induction versus maintenance?
No, my understanding is that the schedule is similar, but the dosage is decreased. So, you're still receiving your medication every 3 or every 4 weeks. It's not like you're going 3 or 4 months without treatment. It's just
Yeah.
lower dosages.
Okay. Um, This has been awesome. I appreciate everybody's questions. How familiar are you, as we jump back into MRD, how familiar are you with mass spectrometry?
So that, it's something I've been reading about. I don't use it clinically, but we're all excited about this idea of being able to use peripheral blood to be able to detect, at a microscopic level, how much cancer you have. And so in my mind, the next 5 or 10 years, we're going to have MRD testing, influencing our treatment decisions. We'll hopefully be taking people off of maintenance, and we'll be having tests like mass spec to help guide us to say, how much myeloma is actually there. And hopefully I'm able to answer that question without doing a bone marrow biopsy.
Yeah, yeah. I see some people saying that they are not high risk but have Velcade. It also has to do with kidney involvement, right? Because the Revlimid, you have to be careful with kidney involvement. So that
Exactly.
might be another reason. And it might just be, again, provider dependent, but
There's good data for bortezomib.
yeah. Okay, so finishing the MRD conversation, Maureen's wondering, why don't all institutions now use the peripheral blood MRD testing? It's just not standardized from what I understand, and there's just so much more research, is that correct English, to do in this field.
Yeah,
Is
we
that
need more data to support these decisions. But there was a time when, for example, daratumumab wasn't a standard treatment, but now it is. These things change over time, and that's the importance of research, and I think the importance of patients and providers asking these tough questions.
Yeah. Back to the statins really quickly, and back to this whole theme of, this is patient dependent. I have one patient saying, I'm doing much better off statins, and another saying, there's a really great study that shows that high statins improve survival. So again, I love research, love that these studies exist, but it really is patient dependent. And this is why being like an informed patient is so important. So thank you everybody for sharing, because it makes me happy. Okay, so let's finish with we'll do 2 more questions, I think. This one, they are on dexamethasone for maintenance therapy. Any suggestions for controlling weight besides not eating?
Yeah.
And would you ever consider a dose reduction in dexamethasone in the maintenance setting?
I mean, I consider a dose reduction of anything if it's making a patient miserable. So, I think that's the kind of the first disclaimer is that, like, yes, these are recommended dosages, but if they're, destroying your quality of life, then we need to do something different. But in terms of what to do about the weight gain, I actually don't have great ideas. I know there's a lot of discussions about the diabetes medication Ozempic and appetite suppressant. I don't know if that's been used at all in kind of steroid-induced weight gain. But I feel like the steroid weight gain is just kind of a side effect that we have to deal with.
Yeah, we do have a side effect solutions tool that has like weight gain as one of the side effects and different crowdsourced solutions to that. So I can include that as part of our follow-up email with the recording and the resources and stuff. Okay, so last question here. Okay, so Kevin says, what is your opinion on BSAs for maintenance? I don't know what that is though, do you? Okay,
BSA.
Kevin, can you clarify? And then we'll include your question, okay? Okay, what does this question say? I was found to have,
Maybe bisphosphonates. I'm not sure.
oh, maybe. Okay, I'm just gonna read this question because I'm having a hard time figuring it out. My first B&B did not gather enough marrow to complete the fish. Oh, that's so frustrating. I was found to have a 1Q gain and 0.17p deletion, but no data for translocations of chromosome 14. What are the odds that a 1Q gain includes a translocation 14 of some kind?
So I do not routinely see, I think there are 5 or 6 high risk features. I do not routinely see all of them met. All it takes is one. All you have to do is meet one of the criteria in order to be considered high risk. I have seen 1 or 2, so it doesn't seem implausible to me that you could potentially have a 1Q gain and deletion 17p, but I would not expect someone to have, both of those plus a translocation for 14 plus a 14/16.
Yeah,
Generally all it takes is one of those to be considered high risk.
it's called ultra high risk if you have 3 or more, and it's very rare in myeloma, correct?
That's right.
I'm learning. Okay. Um, okay, awesome. This is just lots of great. Oh yeah, okay. Back to Kevin. Yes, he said bone strengthening agent. So Kevin's question is, what is your opinion on bone strengthening agents for maintenance? And do you think monthly dosages are better than every 3 months? And then we'll
Yes.
end with that one.
So I don't think about the bone strengthening agents necessarily as maintenance treatment. I think about them similar to like the antivirals or antibiotics that you might take as prophylaxis, during induction treatment. I think about the bone strengthening agents as prophylaxis for future bone issues.
Mm,
Okay. So I think that's separate from the maintenance, but it is important.
yeah. Yeah. And in terms of what was the last part of his question? Um, oh gosh, I hate when I have to. Sorry guys, I know we're at the end of this. Do you think monthly dosages are better than every 3 months?
Yeah, I don't know if one is better than the other, but personally, my practice is to use every 3 month dosing just because it's easier and more practical to give. But
Yeah,
I
I'm with
haven't
the
necessarily seen great data to say that what monthly is much better than 3 months.
yeah, yeah. Okay. Well, thank you. Thank you so much, Dr. Patoki. This is excellent. Again, the way that you present is just, you found your calling to be in myeloma, I think. And I just thank you for taking the time out of your evening to be here with us. Are there any closing remarks you'd like to make before we finish up today?
No, I just want to say thank you to everyone for joining and for asking these questions. As I mentioned, these are questions that we as a myeloma community don't have definitive answers for. And so, so much of this is driven by the needs and desires of patients. And so please continue to stay informed. Please continue to ask your physicians the really, really tough questions because that's the only way the community as a whole will move forward. But thank you.
Thank you. I hope you can see all of the positive feedback that you're getting right now. Well, I'll let you go and just keep my audience for a little bit longer, but you have a good night. Dr. Fatoki, thank you so much.
All right. Good night, everyone.
Okay, so to my audience, we're going to be meeting a couple times this week and then next week. So if you would like to join us on the 31st, we have our amyloidosis chapter. Dr. Zonder is going to speak to us about why is amyloidosis so harsh on the kidneys and the heart. And then the first at 6:30 p.m. Eastern is our Southeast myeloma chapter. It's already June. Can you guys believe it? And then we're going to be talking about fitness and motivation there with HealthTree coach Kenny Caps. And then on the 6th at 1 p.m. Eastern is our myeloma financial chapter. Diana Valentine, who's our financial program manager, is going to be going into what's happening with these Medicare Advantage changes and Medigap. The link to sign up for any of those events and more events I didn't mention is found at the bottom of the slide and will be included in our follow-up email. Special thank you to our sponsors again, Amgen, AbbVie, Adaptive Biotechnologies, Janssen Oncology, Genentech, and Bristol Myers Squibb. And thank you, each of you, for helping us build this community. As you know, I care about you deeply, and I'm just so grateful that you're here and we're learning together. Take care, everyone. Bye-bye.